So I hope I'm audible. If you have any doubts, you can post it in the chat section. I'll be more than happy to answer them at the end of the lecture. So let's begin with the lecture. So starting off, very important module. We started yesterday with one important concept, which was biliary atresia. So if you have seen the diagram yesterday, we saw that there are three types of biliary atresia: distal to the joining of cystic duct, at the confluence of the common hepatic duct, and extending into the liver. So whenever the biliary atresia is extending into the liver, the main procedure of choice is always going to remain the Kasai's procedure. So Kasai is also called as a portoenterostomy. So whenever you are going to do a portoenterostomy, mind you that it is a temporary procedure. Later on, the child is going to require a liver transplant definitely. A child is going to almost require a liver transplant definitely. It is going to be a temporary measure, but remember that it should be done within 6 to 8 weeks, or else the mortality is going to rise to 50%. We have already seen that. So referral is critical in these cases. Now coming to the second important thing, which is called as a necrotizing enterocolitis. So what is necrotizing enterocolitis? When a baby is born prematurely, the supply of the GI tract is not well developed. Along with that, there are some microorganisms in the GI tract which are not yet cleared by the meconium. So what happens is, it affects the preterm low birth weight infants, also in full term infants with some congenital heart disorders. So what happens is, you know that whenever you are starting to run, whenever you are in stress, automatically the gut blood supply reduces. That is the whole point here. When the baby is in the congenital cardiac conditions, what happens is the blood supply to the bowel is going to reduce. So it is kind of an ischemia to the bowel, which leads to something called as a necrotizing enterocolitis. What happens is, there is ischemia to the intestinal mucosa and there is bacterial translocation. So we know that mucosa acts as a barrier for bacteria. The bacteria don't enter into the blood because of the viable mucosa. But when the inflammation is going to rise very high, it can also lead to transmural necrosis. So according to the grades, according to the different types of ischemia and the characteristics, we have graded the necrotizing enterocolitis into three different grades. So what is the thing which you are going to see? There is going to be a bilious, vomiting with abdominal distension and rectal bleeding. So always remember, the rectal bleeding is because of the ischemia, the mucosa sloughs off, which feels as the bleeding. Also there is going to be abdominal distension. Why is there an abdominal distension? So abdominal distension is predominantly there because of ileus. The abdominal distension is predominantly there because of ileus. And in the X-ray, if you are going to do an X-ray, you are going to see certain characteristics which I am going to tell you in the diagram. So what happens in the necrotizing enterocolitis? One should remember that the first thing where the baby is going to start, the first stage of the necrotizing enterocolitis is going to be temperature instability and bilious aspirate. There is not going to be any typical features seen on the X-ray. There might be just bowel dilation on the X-ray. In the second part, the second stage of the disease, when you are going to do an abdominal X-ray, you can see what is called as a pneumatosis intestinalis. So you can see the gas between the layers of the bowel wall, and that is very important to distinguish because it is an emergency, and here you need to give high IV antibiotics and you should give bowel rest for 10 to 15 days. So that is the time you should initiate the TPN, because we saw that the body can tolerate hypoglycemia for 10 days and baby can tolerate hypoglycemia even lesser. So you should begin the total parenteral nutrition as soon as possible for the baby. In few books, pneumatosis intestinalis, in the pediatric books, it might be given. These stages are divided into 1A and 1B. So in few books, 1B is pneumatosis intestinalis, but when we are talking about surgery, it comes into grade 2A. Grade 2B is when this gas, the gas from the bowel wall, is going to escape into the portal vein. So whenever the gas escapes into the portal vein, you can see a portal venous gas. It is called as portal venous gas. So these two things are very much highly suggestive that the patient might land up into bowel perforation. In grade 3, the patient is already landed into perforation peritonitis with the collapse. So the air is now into the peritoneum. So in first grade, according to pediatrics, the air was in the bowel wall. The second layer, the air was in the portal vein. The third grade, it is already into the abdomen. So these are the grades where the air is going to subsequently be seen and the severity is going to increase. The surgical indication is very much important only when there is perforation or peritonitis. So a peritonitis is an absolute indication for a laparotomy. So what is the incision for a laparotomy? It is always going to be a transverse incision in the child. So a child might deteriorate despite the maximal medical therapy. And in adults, mind you, we discussed the short bowel syndrome. There are three types of short bowel syndromes in adults. If you can recall, type 1, yes, a type 1 is where the fistula is ending on the tract. It is end jejunostomy. Type 2 is where ileum is resected. And type 3 is where jejuno-ileal anastomosis is done. If you can recall, go back into the nutrition chapter where we have discussed the short bowel syndrome. So in short bowel syndrome for children, 40 centimeter is the cutoff criteria for short bowel syndrome in a child. What is malrotation and volvulus? So one important thing is, in a neonate, bile stained vomiting in a neonate is equal to intestinal malrotation, or it might be a volvulus unless otherwise proved. So any neonate, when he has a bilious vomiting, the first thing you should click into your mind, it is a midgut volvulus. Normally what happens is, if we try to go into the embryology, we will need to spend another half an hour in the lecture. Basic common point to know is that whenever there is going to be the bowel which comes out of the umbilicus in the baby, that is the vital intestinal duct, when the bowel is taken back into the abdomen, the rotation is 270 degrees counterclockwise. So 3 rotations happen, 90, 90 and 90. 3 of the rotations are counterclockwise, and then the cecum goes into the right iliac fossa and the small bowel is going to come anteriorly. So whenever you are going to suspect a small bowel obstruction, the malrotation is the first common cause which is going to cause the volvulus. So always keep the malrotation in mind. And why is that malrotation happening? Because there is something phenomena which is called as a Ladd's band. So there is a peritoneal band which crosses the duodenum, and that is the reason the small bowel cannot rotate properly, and that Ladd's band is going to cause obstruction. So what is important? 270-degree rotation takes place. Whenever the rotation is abnormal, I am going to call it as a malrotation. Why is the malrotation in neonate seen? It is seen because of the Ladd's band. So 4 interrelated things: bilious vomiting because of midgut volvulus, because of malrotation, because of Ladd's band. So that is the most common thing I'm talking about. There might be other causes. There might be some other causes like, necrotizing enterocolitis, or there might be other causes related to some congenital bowel atresia, jejunal atresia, duodenal atresia. But the most common cause of bilious vomiting in a neonate is the flowchart which I told you. So bile stain vomiting in a neonate, is midgut volvulus unless otherwise proved, and it is always a surgical emergency because you can lose the entire midgut. The bowel has rotated along this axis, the mesenteric supply has been cut off. So if you are not going to intervene within the specified time, the mesentery will land up into necrosis and the small bowel will go for a toss. And less than 40 centimeter small bowel, it is going to lead to a small bowel syndrome. The incision preferred, it is going to be a transverse incision on the abdominal wall. So here you can see that this is the Ladd's band. So this Ladd's band is going to cause an obstruction beneath the duodenum. So you can see that here it is the duodenum which is going for a toss, and because of that there is going to be a bilious vomiting because of the Ladd's band. And what is the procedure of the choice? We are going to do what is called as a Ladd's procedure. So what is the Ladd's procedure? First, you are going to cut this band. This is the problematic band, so you are going to cut this band. So that is the cutting of the band. Then we are going to do an appendectomy. So appendix is removed. So that is the second step of Ladd's procedure. Third step is going to be, you are going to, because of the malrotation, now you cannot restore the normal anatomy. Though we are surgeons, we are not God. So we cannot place to the normal anatomy as the God is actually designing. So whenever you are going to go for a malrotation surgery, we are going to place the small bowel to the right and large bowel to the left. So this is very much important. On the right, we are going to place the small bowel. On the left, we are going to place the large bowel. So this is called as the Ladd's procedure, which you are going to do for surgery. So in acute volvulus, it is going to be a bile stain vomitus. There might be vascular compromise. So emergency laparotomy is required. Incision is always going to be a transverse incision. Chronic malrotation, it is because of an intermittent pain, failure to thrive, protein losing enteropathy. So whenever the patient has a chronic type of the obstruction, here you can build the patient and then take for surgery. Management of choice is the Ladd's procedure. What is the Ladd's procedure? We are going to divide the Ladd's band, broaden the mesenteric root, appendicectomy is done. Broaden the mesenteric root as in take the vertical incisions on the mesentery. So whenever you are going to take the incisions on the mesentery is going to open up. So whenever the mesentery is going to open up, that is going to be mesenteric lengthening procedure. So that is important when you are going to deal with Ladd's procedure. So what are the 4 things? Remove the Ladd's band, you are going to broaden the mesentery, do an appendicectomy, and 4th important thing is you are going to place the small bowel to the right and large bowel to the left. So it is very much important. If midline is crossed during the operation, so as right now I told you that we are going to make a transverse incision, but whenever you need to cross the midline in a transverse incision, you are going to ligate the umbilical vein first, because we know that in fetus the umbilical vein, in the neonate the umbilical vein is functioning. So you are going to first cut the umbilical vein and then you are going to go to the other side. So it is very much important to know about the volvulus. Whenever a short note is going to come to you in neonatal volvulus in pediatric surgery, the first thing you are going to talk about is the malrotation, the Ladd's band, and what procedure are you going to do. A short note might come, which is very much important. What is gastroschisis? Even in NEET PG, the question was asked, what is not the component of Ladd's procedure? So all of the 4 components are there except someone is given, so you have to just point it out. So it is very important for NEET PG as well. Sir, what is gastroschisis versus exomphalos? So these are two important short notes or distinguish which comes in your papers for UG, PG as well, and it is also asked in your NEET PG exams. So what is important is gastroschisis is a defect lateral to the abdominal wall. So it is not in the exact midline. The gastroschisis defect is always going to be somewhere right paramedian. It almost 90% of the times it is going to be right paramedian. But omphalocele is the defect in the umbilicus. So when the umbilicus is defective, when there is going to be a herniating content without the skin over it, directly covered by the peritoneum, it is called as an omphalocele. So in gastroschisis, the wall is deficient, so the bowel is popping out directly. Here the bowel is exposed and there is no covering to the bowel. But here in omphalocele, it is the peritoneum which is going to pop out because umbilicus is not fused. As the umbilicus is not fused, there is going to be a peritoneal sac which is going to cover up the bowel. What are the associated anomalies? So always remember, gastroschisis is due to some insult on the right side of the abdominal wall. So because of that insult, only the gastroschisis segment is 99% of the times present. There are no other congenital anomalies to the child 90% of the times. But if a congenital anomaly is present, what is the congenital anomaly present with the child? So another important point, the only congenital anomaly which is present, which it can be right undescended testes. It can be there. But in omphalocele, remember that the umbilicus is not closed, so there might be some genetic alteration to the child. So always and always, whenever you are talking about the omphalocele, there are other congenital conditions which are present, like cardiac or chromosomal conditions. So typically for pediatrics points, I have mentioned them, Beckwith-Midman syndrome or trisomy 18 or 13. So it might be associated with omphalocele. Location is always to the right of umbilicus, as we told, right paramedian, and here it is through the umbilicus. Maternal age, so always remember, whenever maternal age is young or teenage mothers, it is more common associated because the mother's physiology is not well developed, so the blood supply might get hampered, and that is the reason it is going to happen. And omphalocele, as we know that as the lady ages, the more congenital anomalies can be seen in the lady, and that is the reason why it has chromosomal associations, and hence omphalocele is seen in the older women. Bowel appearance is matted and oedematous because bowel is exposed to the external surface. So bowel is always oedematous and it can be matted because it is exposed to the external surface. But here in omphalocele, the bowel is covered by the sac, hence the bowel is always going to be normal. So here it can be associated with undescended testes. So very important point to be noted here, and it is not associated with undescended testes. Management can always first you are going to cover the bowel, because bowel, if exposed a lot of time for the environment, it can go for necrosis. So always and always the first thing you are going to do is you are going to cover up the bowel. So silo is a dressing which can be applied to the bowel bedside, and then you can take the baby to the NICU, stabilize the baby, and then you can go for staged reconstruction. You can go for a staged bowel reconstruction. And omphalocele management, it can be divided into minor or it can be divided into major. So when it is a minor, you can apply just the antibacterial dressing. So what are the antibacterial dressings? Silver sulfadizine is applied. Even honey can be applied. Honey means not actual honey which we get. There is a medical honey which is sterilized. So that sterilized honey can be applied because honey is going to promote granulation tissue, and then you can go for a delayed closure. So when granulation is going to develop over the peritoneum, you can push it in and then you can suture. Never suture an omphalocele. Never suture an omphalocele immediately, because if you are going to do it, the bowel contents which are going to go inside suddenly, it can cause abdominal compartment syndrome. So what is the cutoff for abdominal compartment syndrome? If you can put it in the comment section, I will be more than happy to see your answer. Prognosis. So gastroschisis, it is not associated with any other anomaly, so prognosis is excellent. But here, what are the anomalies present along with it? So it depends on the anomalies which are going to be present. Hence, the omphalocele prognosis is always dependent on the concurrent anomalies. Another important thing which you are going to deal with is the congenital diaphragmatic hernia. It is a very common condition which is encountered these days because of maternal extra maturity. That is the most common cause. And why it happens is because of the developmental defect in the diaphragm. You know that the diaphragm develops from the diaphragm has the two components. One is the central tendon and another is the peripheral component. So that central tendon from the septum transversum which is developed, there might be some defect in that, and that is the reason why the hernia is going to be developing. Most commonly seen on the left side and left posterolateral hernia. So there are two types of hernia. One is a Bogdalek hernia and another is a Morgagni hernia. So Bogdalek hernia is the left posterolateral, and exactly opposite. All these words, if you are going to go opposite to them, Bogdalek is left posterolateral, Morgagni is going to be right anteromedial. So there are going to be two defects. One is left posterolateral, another is right anteromedial. So right anteromedial is Morgagni. So because of the proper investigation nowadays, because of good antenatal scans, because of good anomaly scans in the prenatal period, it can be diagnosed before the birth of the child. So what is the important factor you are going to check when the child is going to be born? What is the problem which you are going to face? You are going to face is the problem is going to be if the lung is developed or not. So here you can see that liver is coming, the spleen is already here, the bowel is here, so the development of the lung might be hampered. So how is the radiologist going to check the hamperment of the lung? Because you know that the lungs are not ventilating, so you cannot actually check the ventilation of the lung. The x-rays cannot be done in the antenatal period. So here what we are going to do, what is called as a lung to head ratio. So we are going to compare the volume of the lung to the head of the baby. So what are we going to do? Lung to head ratio is done. LHR is done. So whenever a congenital hernia is given on the antenatal scan, the first thing you are going to ask the radiologist is what is the lung to head ratio, and it is going to predict the pulmonary hypoplasia. So you don't need to go into the details how much of the lung to head ratio is important, what is abnormal, what is normal, but at least you should know that how is the antenatal scan going to detect if the patient is going to have congenital diaphragmatic hernia, and also if it is there, is it going to be very severe or is it going to be mild? So LHR is going to tell you about the development of the lung. So there might be associated cardiac defects, foregut malformations or pulmonary hypoplasia. So cardiac defects and foregut malformations can be because of chromosomal abnormalities, and pulmonary hypoplasia is because of the compression of the lung from outside. Key principle is, again, as we talked in IHPS, if you remember, it is not a surgical emergency. So do not rush to the OT. Stabilize the patient first and then you are going to go for the OT. And two important things is no bag and mask ventilation. So if the baby is having any issues, you have to straight away intubate the child. So intubation is always done, because you know that whenever you are going to go for a bag mask ventilation, some air might go into the stomach and bowel and this portion is going to increase. So when this portion is going to increase, automatically the lung compression is going to increase and that is going to cause more problem with the baby. Hence never you are going to go for a bag and mask ventilation. And what is to be done? You can go for a permissive hypercapnia. When you are going to increase the CO2, it is going to reduce the airway pressures. So whenever CO2 is increased, automatically the vasoconstriction is going to take place, the pulmonary edema is going to reduce, and it is only for an escape mechanism. It is not going to be an emergency. So always remember that whenever you are dealing with it, you have to, for an emergency purpose, you can go for permissive hypercapnia, but it is not the definitive line of management. No bag and mask ventilation before intubation. So it is very much important. And if the baby is still not tolerating, even after intubation, the baby is not maintaining, if the child is affording, if the parents are affording, you can straight away go for what is called as ECMO. So consider for extracorporeal membrane oxygenation. So you can take the baby on a lung machine. Like dialysis, you can take the patient on ECMO. So what is ECMO? It is going to oxygenate the blood and it is going to send the blood through. So ECMO is very expensive. It was there in COVID times also. So whenever the patient's lung used to be severely damaged, till for the recovery of the lung, the patient was shifted to an ECMO. So ECMO can be done for the baby. Surgical repair is performed when the baby is actually stabilized and when the pulmonary hypertension is under control. So most important thing to be noted here is pulmonary hypertension, which needs to be controlled. And large defects require synthetic patch. So never a mesh in a baby. So it can be a stylistic patch which can be done. So you can take some muscle and you can implant it there, or you can use any congenital hernia sac. So whenever a hernia sac is present, you can use it for a reconstruction. But always remember, as we are done in inguinal hernia, no placement of any mesh in the baby, because the mesh is going to shrink, the baby is going to grow, and it might cause complications in future. So no meshes in the baby at all. Now we are going to talk about some important thing which is called as an anorectal malformation. What is an anorectal malformation? So the first important thing is when the anus is not going to develop. So no development of the anus. When the anus is not going to develop, then the baby is going to land up into something which is called as an anorectal malformation. So if the anus is underdeveloped, what can happen? Either, so let's consider that this is the pelvis cavity. So this is the cavity of the pelvis and this is the levator ani muscle. So this is the pelvic cavity and this is the levator ani. So normally what happens is, you know that while formation of the rectum and anal canal, you know that the hind gut is going to come from above and cloaca is located in the embryo, which is in the lower pole of the embryo. So that cloaca is going to differentiate. The cloaca differentiates into two components, that is a rectal anorectal sinus and the urogenital sinus. So when it is going to divide, this anorectal sinus is going to anastomose with the hindgut. So what if there is going to be some problem with this anorectal sinus, it is not going to properly anastomose, that is the time when the baby is going to have some anorectal malformation. So rectum is not well developed. So if you are going to examine the baby properly, the pediatrician is going to check for the anal cavity patency. So when the anal cavity is not patent, that is the time you are going to call it as a anorectal malformation. So there are two types of anorectal malformations. So if the rectum ends above the levator ani muscle, so what is the defining factor between these two? So the defining factor between these two is nothing but your levator ani muscle. So the levator ani is going to differentiate if it is a low ARM or a high ARM. So if it ends below the levator ani muscle, it is considered to be a low ARM. Because it is coming down near the skin, the management is going to be comparatively easy. So low is going to be easy to tackle. Low is going to be low maintenance, so it can be easy to tackle. But in a high ARM, the anal canal is not developed and levator ani to the perineal skin, that much distance needs to be covered. So that is the time when the baby requires some amount of development in view of feeding. Because there is no anal canal, the baby cannot pass the meconium. So the first thing to strike is going to be, whenever the baby is not passing meconium for at least for 12 to 24 hours, first check the patency of the anal canal. If the anal canal is patent, well and good, but if it is not patent, then you need to think about some congenital abnormalities or something related to the obstruction. So what can you think about? The first thing we saw is going to be, yes, we saw about the midgut volvulus. So baby is going to have vomiting. Another thing might be an anorectal malformation, which is we are discussing. Another thing important, yes, we know about cystic fibrosis. So in cystic fibrosis, the mucosa is going to be very thick and hence the baby cannot pass the stools very easily. Another important thing you can think about is the Hirschsprung's disease. In Hirschsprung's disease, the colonic segment, there is an agangliotic segment which we are going to discuss in the subsequent slides. So what is going to divide the ARM? So anorectal malformations can be divided into low and high based upon the levator ani component. So rectum passes through the puborectalis. A puborectalis is nothing but a part of levator ani, and there is a fistula at the perineum. So there might be a fistulous opening near the perineum, maybe or might not be. And what are you going to do? You are going to place the baby in a prone position. This is an emergency. You need to take this baby for OT emergency, or else the baby won't pass the meconium and the baby might land up into obstruction, distension, and finally it might lead to perforation. So you need to take this patient immediately into the OT. And what is the procedure of choice? The procedure of choice is always going to be PSARP. What is PSARP? Posterior sagittal anorectoplasty. So what are you going to do? Typically, if you are going to see this photo, what is this? So whenever you are going to place the baby in the prone position, you are going to open near the midline. Always remember that you are going to do a coccygectomy. So you are going to remove the coccyx. So coccyx is removed, and then you are going to pull the rectum below and you are going to make a new anal opening. So a new anal opening is formed here. If you can see rightly in the diagram, a new anal opening is formed here. So this is nothing but PSARP, posterior sagittal anorectoplasty. Always remember, what is the investigation of choice you are going to do? The investigation of choice which you are going to do in this baby is going to be an invertogram. So what is an invertogram? You are going to place the baby, whenever you are going to rotate the baby inverted, and whenever you are going to do an X-ray, normally you can see, and you might place some bead near the anal canal. So whenever you are suspecting an anal canal, you should place a bead in that cavity. So normally the distance between that bead, there should be air around the bead. It will indicate that the air is reaching till the anus and the rectum. So whenever the baby is inverted, the air will naturally float up and it is going to occupy the area which is surrounded by the bead. But when the air is not reaching here, so this, what we can see here, this is nothing but an invertogram. So you can see that this is the skin crease, but here the air is only reaching up till here. So it is the defect which is going to be seen. So this same invertogram can be also used to identify if the defect is high or low. But nowadays advanced investigations are there, CT scans and MRIs. CT is not preferred, but still MRIs can be done, and the invertogram or the MRI can be used to detect if it is a high or low defect, where all the fistulas can open. So what is high ARM? High ARM is when the rectum ends above the levator ani, and there might be a fistula with the bladder neck. So fistula to the bladder neck is very much important to diagnose here. So whenever the baby is passing stools from the urine or perurethral, you should suspect that it might be a high ARM based on the clinical findings. And whenever you are suspecting a high ARM, always a defunctional stoma first and then definitive repair. So whenever it is a low ARM, so whenever you are suspecting an anorectal malformation, so let's make a small flowchart. So anorectal malformation divided into two components. Firstly, you are going to judge it on basis of invertogram. It is going to tell you, or you can also do an MRI. It is going to tell you if it is levator ani is going to divide it into high and low. If it is low, you can straight away go for a PSARP. But here in high, you are first going to go for something which is called as, you are going to go for a divergent stoma. And then you will go for the definitive procedure, which is PSARP. So this is important for you to know. Whenever you are managing a patient of anorectal malformations, these things need to be kept in mind. So bladder neck fistula and a urethral fistula. So bladder neck fistula, when it is going to be a high ARM. Urethral fistula usually when it is going to be a low ARM. So always whenever it is a bladder neck fistula, you need to approach it from the abdomen as well, because you need to cut the fistulous tract. So whenever there are fistulas in the abdomen, nowadays what they do is they do a staged laparoscopic repair. So it is called as LAARP. So it is a laparoscopic approach which they are going to do nowadays when they are going to approach it from the abdominal cavity. And cloacal anomalies in the girl can also so in the girls, the most common site of opening might be into the perineum or in the vestibule. So sometimes in female, that anorectal malformation can open at the vestibule or inside the perineum. So perineal opening of urethra, vagina and rectum. So there might be a single opening which might be present in the vestibule, and it is a complex repair because we need to also reconstruct the vagina, also reconstruct the urethra, and also reconstruct the rectum. So reconstructive urology, reconstructive gynecology. So it is very much important, the super subspecialty which is developing these days. Nowadays what happens is most of the times these diagnoses are done prenatally. So a lady might go and land up into the MTP, but whenever it is not detected, then whenever the parents are ready to invest a lot of money, these tertiary care procedures come into play, wherein we are going to think about it. So now talking about the Hirschsprung disease. So it is when the ganglionic segments, normally you know that whenever the colon is forming, the cells which are going to cause the motility are going to come from what is called as a neuroectoderm. So absence of the ganglionic cells in the meyenteric or submucosal plexuses, these are going to this is going to give rise to a segment which is not going to be contracting. So this is going to be the normal colon, and there might be a segment wherein the peristalsis is absent. So here the baby is going to have difficulty in passing of the stools. So whenever you are going to encounter such condition, the anal cavity is patent, invertogram is normal, but baby is not passing stools, think about what is called as Hirschsprung disease. It might be associated with what is called as a Down syndrome. So Down syndrome is one of the most common thing which is associated with Hirschsprung disease, and most common site is always going to be a rectosigmoid region. And there is a rare variant which is called as total colonic aganglionosis. A total colonic aganglionosis means the whole colon is not going to have any type of ganglion cells, which is very rare and also fatal for the baby. What is the presentation? Delayed passage of meconiums more than 48 hours, abdominal distension and bilious vomiting, features like enterocolitis. So you need to suspect it very much early when you are going to think about it. Diagnosis is based on rectal suction biopsy. So what do you do? Usually when you are going to do a proctoscopy for the child, at the rectosigmoid junction, whenever you are going to do a proctoscopy for the child, this is going to be your rectum, this is going to be your sigmoid. So whenever you are going to do a proctoscopy, you can just pull out the mucosa. Suction mucosal biopsy is going to be done, and there you can find the absent ganglionic segments and with hypertrophic nerve fibers. So no ganglion, but nerves are hypertrophic. So that is going to be the gold standard. But always remember, sir, biopsy किधर से लेने का? Biopsy dilated segment से लेने का या constricted segment से? So always you are going to go for the junction where the constriction is beginning. So always take the biopsy from the junction where the constriction is beginning, not from the dilated segment. If you take the biopsy from the dilated segment, everything is going to be normal. So biopsy कहाँ से लेने का? Biopsy to be taken from this point. So always remember biopsy कहाँ से लेने का? Sir, what is the immediate management? Surgery लेने का क्या? No emergency surgery. The first thing you are going to do is the rectal washouts. Whenever you are going to push the fluid in the rectum, the stool is going to become liquid and it can easily pass without peristalsis either. So it is a temporary measure which is going to decompress the colon and prevent enterocolitis. Then you can go for what is called as a defunctioning stoma. So in emergency, you can go for a stoma. Again, we told that while talking in the pediatrics module, the first module which we discussed yesterday, always mark the stoma triangle properly because umbilicus is low lying in the baby. So stoma placement is very much important here. pull through procedure. So there, what is the definitive surgery? So when the baby becomes stabilized, when the baby can be taken up for the surgery, there are 3 procedures which can be done. So what is the procedure? So whenever you are going to resect the aganglionic segment, so this is the aganglionic segment, you are going to resect the segment and do a primary anastomosis. It is called as a Swesson's procedure. So resection is a Swesson's procedure. When you are just going to remove the mucosa, we saw that there might be problem with mucosal plexus or a mesenteric plexus. So if mucosal plexus is involved, only a mucosectomy can be done. You don't need to re-anastomose the whole bowel. So just mucosectomy, when you are going to just remove the mucosa, it is going to be called as a Soave procedure. And what is another procedure which is done to prevent resection? What do we do? Let's consider this is the constricted segment and this is going to be the dilated segment. This is going to be the dilated segment. What are we going to do? This is the segment wherein the ganglionic cells are going to be absent. So what do? We are going to take this segment down. So how is it going to look? So this is going to be the constricted segment. Here the ganglion cells are going to be absent, and now we are going to do a side to side anastomosis of this bowel wall. So what happens is the stools are now going to pass from here, come down. So this is going to be called as something which is going to be a Duhamel's procedure. So these are just procedures. The name of procedures are just enough. MCQ might come. All of the 3 are procedures for Hirschsprung disease except so Swesson, Soave and Duhamel procedures. So these are the 3 procedures we should know. So Swesson, Soave and Duhamel procedures. You are going to remove the aganglionatic bowel. And what is a Hirschsprung's enterocolitis? So it is a life-threatening emergency. What happens is because of the stagnancy of the bowel, because the contents are stagnated in the bowel, there is full-blown enterocolitis to the child and it passes explosive stools sometimes, and there is severe distension of the bowel. There is going to be severe distension of the bowel. So you have to give washouts plus IV antibiotics and emergency surgery is required. Always remember there is another sign which is given in the standard surgical textbooks. It is called as a rectal squirt. It is called as a rectal squirt. So what is a rectal squirt? Whenever you are going to give a rectal washout, suddenly the contents are going to blow out. So that is called as a rectal squirt, which is given in the standard textbooks, which you should remember. Hirschsprung's enterocolitis can occur before or even after the surgery. So always the baby needs to be monitored, and you should have high index of suspicion in a child with known Hirschsprung disease. So whenever a child of Hirschsprung disease develops fever, the first thing just think about is a full-blown enterocolitis. So this is very much important for you to know. So I hope it is clear, and here we are ending the chapter of neonatal surgery, and now what we are going to begin is the basic pediatric oncology and basic pediatric things which are remaining. So let's start off them. If you have any doubts, you can post it in the sections. अरे गौरव, हाय गौरव, थैंक यू, थैंक्स. इतना बड़ा नहीं हो रहे मैं, तुम्हारे साथ ही काम करके सीखा हूँ सब चीजें. Great, you are enjoying it. Yes, abdominal compartment syndrome, it is 20 millimeters of mercury, very rightly said. In laparoscopy, we can extend the abdominal pressure up to 13 to 15 mm of Hg. Nice. Chalo, let's begin with what is called as pediatric surgical oncology. So there are few malignancies which are seen in a neonate and the child. So you should diagnose them and you should know basic line of management. You might need not require what are the surgical steps, what is hardcore management, but at least you should know what are the tumors, because they are asked in your NEET PG as well. They are also asked in the undergraduate theory exams, also postgraduate theory exams. So these things are important for you to know. So origin. So always remember the first tumor we are going to talk is the neuroblastoma. Because the neuronal cells are not developing properly, there is something called as a neuroblastoma. Neuroblastoma can be a cranial or extracranial. Cranial neuroblastomas, neurosurgery. Now we are talking about extracranial neuroblastomas, which is dealt by a general surgeon first and then referred to pediatric surgery. So it is going to be origin, which mostly comes from the adrenal medulla, or it might happen from the paravertebral sympathetic plexus. So it is going to be an abdominal mass. Always differentiation point of neuroblastoma is going to be the Wilms tumor. Sir, how to differentiate Wilms tumor between neuroblastoma? So Wilms tumor originates from the kidney and it is always a unilateral. It 99% of the time is not going to cross the midline. But neuroblastoma originates from the sympathetic chain, so it might even cross the midline. So crossing the midline is one of the important clinical parameters you are going to have. And in neuroblastoma, there might be conditions wherein the baby is going to have some neuropathies. There might be some excessive amount of catecholamine secretion. So it might also have some blood problems in the baby. So origin is adrenal medulla. Age is less than 5 years of the age. It is the most common solid tumor in infancy. Most common solid tumor in infancy is always a neuroblastoma and not the Wilms tumor. So always remember, when you are recalling it, first think about, yes, I am thinking about the neuroblastoma because sir taught neuroblastoma first. So neuroblastoma is first, so it comes the most common malignancy. Presentation is a large abdominal or retroperitoneal mass, and important point is it may cross the midline, and there might be associated blood problems like hypertension, proptosis because of the mets, and it might also resemble the raccoon eye. So a raccoon eye in a child without any trauma, it suspects some intraocular metastasis from a neuroblastoma. Tumor marker, urinary catecholamines, if you are going to do, you might do VMA, which is called as vinyl mandelic acid or homovanillic acid. So these are the metabolites, of catecholamines, and these are going to be raised. And AFP is not the marker for neuroblastoma. AFP is not the marker. Many of the books have given that AFP is the marker. Bailey and Love has clearly told that AFP is not a reliable marker for neuroblastoma. Staging, you are going to go for what you call as nuclear imaging. So nuclear imaging is done for infants, and always remember that neuroblastoma is something which can go for a spontaneous regression. A small mass less than 5 centimeter, it has excellent prognosis. You need not operate the patient as well in the initial period, but after going for an OT, it has excellent prognosis. But a large mass, so a first chemotherapy might be given. So always remember, chemotherapy decision is always taken by a pediatric oncologist, not by a surgeon. As in the adult malignancies, you can decide whether you can go for a downstaging of the tumor. But always remember, in pediatric malignancies, you have to involve a pediatric oncologist who is going to tell you if a downstaging chemotherapy is required, or you can take the baby straight away for surgery. The parameters are totally different. It is not like adults that you can go for a lymph node dissection, or you can go for radiotherapy, or you can go for chemotherapy straight away. In child, you have to deal with it very properly, because one wrong decision of you can cost the life of the baby. So always remember, large mass, you can go for a downstage procedure. When it is a small mass, you can go for upfront surgery, no problem. And here you are going to do an MIBG scan. So MIBG scan is nothing but it is one of the type of the radionucleotide scan. It is most specific. So we talked about nuclear imaging when we were talking about CT scans and imaging technologies. So what my point of telling you is, midline crossing tumor having hypertension and proptosis in a young child less than 5 years of age is neuroblastoma unless otherwise proved. Whenever the mass is not crossing midline, whenever there is going to be only intermittent abdominal pain, there might be some urinary symptoms, it is nothing but nephroblastoma that originates from the nephrons, which is called as a Wilms tumor. So age 1 to 4 years, it might be bilateral as well. So why bilateral important? Because if it is unilateral, you can straight away cut off the kidney and you can do a nephrectomy. But when it is going to be a bilateral tumor, you need to go for what is called as a nephron sparing surgery. So unilateral or bilateral, it is very much important. You cannot go for bilateral nephrectomy, or the child's mother is going to sue you and you are going to land up into jail. So always remember, when dealing with Wilms tumor, bilateral or unilateral is the first question you are going to ask. It might be associated with some syndromes, WAGR syndrome. So it is important MCQ for your NEET PG. What is that syndrome? It is Wilms tumor plus aniridia plus genitourinary anomalies plus mental retardation. So WAGR syndrome. W for Wilms tumor, A for aniridia, the iris is not developed, then G for genitourinary tract anomalies, and R is for mental retardation. Or it might be situated with Beckwith, Widman's or Denish-Drass syndrome. So these are syndromes which are associated with Wilms tumor. Wilms is the pet favorite question for your NEET PG exam, so you should be knowing it. Critical exam point is, it does not go for a midline, it does not cross the midline, and always remember, don't go for harsh palpation. Don't go for harsh palpation, because it might lead to tumor rupture and it can upstage the tumor. So whenever you are thinking about a Wilms tumor, don't go for harsh palpation. Always palpate softly. If you are going to palpate it harsh, it might rupture and it might cause seeding. So grade 1 tumor might go into grade 4. Diagnostic is ultrasonography, but here CT is mandatory. And always remember that lung mets are the most common site of metastasis. But still you can go, as we already told you in the basic oncology principle, lung mets can be resected in cases of RCC, so it can be resected as well. So lung mets can be resected when you are talking about any type of the renal tumor. So how do you manage? So basically two approaches are there. One is the UK approach and one is the USA approach. So UK approach, what do they say? They say that go for an upfront surgery. UK approach, what do they say? They say that first you are going to give the chemotherapy and then downstage the tumor. So UK people are conservative. They told that first you are going to give chemotherapy and then you are going to go for a nephrectomy, and then again required you can go for a adjuvant chemoradiotherapy. But in USA, they said that first go for a nephrectomy and then you can go for chemotherapy. So two approaches for Wilms tumor. One is UK-based approach, one is USA-based approach. And in surprisingly, Bilious being a UK-based textbook, they have given both the approaches together. So they have told you that if you are following the USA protocol, you need to go for a nephrectomy first. But when you are going for a UK protocol, give the preoperative chemotherapy. So again, as I said, we don't have to use our minds. We are just the operating hands. Give the case to pediatric oncologists, but you should be knowing that why is the pediatric oncologist giving both the opinions at the same time. He might think that the patient will benefit from surgery first, so then we'll go for surgery. Bilateral Wilms tumor, you need to go for a nephron sparing surgery after chemotherapy. So bilateral Wilms tumor, never surgery. So unilateral tumor, USA or UK protocol. Bilateral tumor, never upfront surgery. First you are going to give chemotherapy. In histology, you are going to check if it is a low grade or a high grade tumor. So again, we don't need to go into the details. If it is going to have the primitive components, so if it is going to have primitive components, it is going to be what you can say, it is going to be undifferentiated. But when the components are well differentiated, they can be go for a low grade tumor, and there you cannot give the chemotherapy. So if it is anaplastic, it determines the chemotherapy intensity which is required. And prognosis, overall 90% survival rate with chemotherapy and surgery. So only surgery cannot cure this tumor. Unlike neuroblastoma, in neuroblastoma we saw that upfront surgery in small tumors can be 100% curative. But here it is not like that. Always Wilms tumor is associated with almost you need to give chemotherapy to each and every child. So chemotherapy decision is taken by the medical oncologist. Refer the case there, and if he says that go for surgery, you should go for the surgery. So you can see rightly see neuroblastoma versus Wilms tumor. So neuroblastoma is when it is, arises from the adrenal gland. You can see that it is crossing the midline. It has also encased the great vessels. So neuroblastoma, and this is called as a nephroblastoma. So it is isolated in the kidneys. It is not crossing the midline. So one diagram which is explained everything very nicely. So I hope both the tumors are clear. Again, for a short revision, neuroblastoma, small in size, go for upfront surgery. Large in size, take chemo opinion. When the Wilms tumor is there, always a chemo opinion is to be taken. Bilateral tumor, never upfront surgery. If it is a favorable prognosis, upfront surgery, then chemotherapy, which is a USA protocol. If unfavorable prognosis, UK first approach, wherein you are going to give first chemo radiation and then you are going to downstage the tumor and then go for surgery. So we know both the approaches. Then comes the third important point, which is the most common malignancy, most common swelling in the child, which is going to be a malignant swelling in the child. So these are the lumps. What we talked about was the lump, which is palpated per abdomen, but most common solid tumor in the newborn is going to be what is called as a sacrococcygeal teratoma. So near the sacrococcygeal region, there might be a swelling. What is the differential diagnosis? One must differentiate it from a meningocele. So meningocele and meningomyelocele must be differentiated, and most common tumor of the newborn, and it has female predisponderance. Till date we were seeing everything in males. Hernia more commonly seen in males. Undescended testes obviously is seen in males. Retractile testes obviously seen in males. But when we are talking about sacrococcygeal teratoma, the most commonly encountered is going to be a female, and it is the most common solid organ tumor which is going to be seen. What is it? It might be something. We know that teratoma means it might contain all the germ layers. So contains mature and embryonal malignal elements. So it might be mixed. It might have some components which are well differentiated and also some components which are undifferentiated. So here the tumor marker is alpha fetoprotein. So we talked about it very well in the neuroblastoma that AFP is not the marker for your neuroblastoma. But in sacrococcygeal teratoma, AFP monitoring is very much important. So three malignancies in a child. One is the neuroblastoma, other is the Wilms tumor, and third is the sacrococcygeal teratoma. So tumor marker is alpha fetoprotein. You can already do a prenatal ultrasound and you can actually detect the risk. And there might be, because of the tumor being highly vascular, there might be high cardiac output through the tumor, and the child might land up into a high cardiac output failure. So you need to take care that this child is thoroughly monitored. So there is a classification which is seen here. So that is called as something which is called as an Altman's classification. So what is that Altman's classification? So whenever you are going to see, type 1 is where the tumor is coming outside. There is no component inside. So maximum tumor is outside. In second, the tumor is maximum outside, but it is going till the levator ani. So maximum tumor outside, but going till the levator ani. In the type 3, you can see that tumor is outside, but it is extending more inside the cavity. And last one, it is only inside, not seen. So most common is type 1 again, but here it is the most common. Almost always remember, when you are answering anything in surgery, most common thing, it is almost the type 1. Exceptions are a few. We are going to talk about those exceptions later on. So whenever they are asked what is the most common site of malignant, what is the most common type of dash, so type 1 is always going to be the most common answer. So type 1 predominantly external, type 2 is external plus presacral component, type 3 is going into the pelvis and abdomen, and type 4 is entirely presacral and internal, and it is often missed at birth. It is going to present later with constipation. So what is the management of choice? Here it is going to be complete surgical excision, including the coccyx. So as we talked about PSARP, in PSARP also you are going to remove the coccyx. In sacrococcygeal teratoma also you are going to remove the coccyx to prevent the recurrence. And in large tumor you can ligate the median sacral artery, because the blood supply of these tumors come from the median sacral artery. The blood supply is going to come from the median sacral artery, so you can ligate the median sacral artery here, and then you can go for a perineal dissection. So first go laparoscopically, ligate the median sacral artery, and then you are going to start the perineal resection. So it is going to prevent the catastrophic bleeding. So dual approaches in a surgery. A child's mother might ask, sir, why do you want to operate on the abdomen if the tumor is in the perineum? So you should tell them that the blood supply is coming from the abdomen, so I need to ligate the median sacral artery so that the blood supply to the tumor is reduced and child will end up into better surgery with less bleeding. Malignant transformation is typically seen with delayed treatment. It happens in type 4. Why? Because type 4 is missed. Type 4 is not seen externally, it is purely internal component. As you can see, the type 4 sacrococcygeal teratoma being an internal component, it is missed high likely, and because of that there is high risk of malignant transformation, and post-op AFP monitoring is to be done. It should ideally normalize within 6 months. So these are the tumor markers. So it should usually be getting normal within the 6 months. So I hope these tumors are clear. 3 tumors very much important in child oncology for surgical perspective. There are other leukemias and blood malignancies beyond the scope. 3 malignancies: Wilms tumor, neuroblastoma, and sacrococcygeal teratoma. So these 3 tumors should be by heart at any level, UG, PG, or your NEET PG level. Now we are going to talk something about pediatric trauma. So we already know the trauma. We already have seen the great trauma module in detail. Almost 3 lectures are covered with trauma. So now I'm just going to run through what is the difference in the child and what is the difference in the adult. So when you are dealing with the child, whenever you are dealing with the child in the cases of trauma, you should know few things. So airway, always remember there is no jaw thrust, always head tilt and chin lift, and prevent hyperextension, because the head is heavier as compared to the spine. The spine cannot take the head, so there is high risk of C-spine injury. First difference. Second difference is breathing. So here the ribs are flexible. So always remember, even if the chest compression test might be negative, even if the X-rays show no amount of rib fractures, or you're not suspecting any rib fractures, there might be a pneumothorax inside. Because the ribs are flexible, they might indent to the pleura, puncture it, and again come back to normal. So pneumothorax and contusions can be present despite rib fractures, and hypoxia is the primary cause of cardiac arrest. So most of the times you will feel that, oh, there is no rib fracture, I am not worried about it. No rib fracture, no chest trauma. No, it is not like adults. In adults, a rib fracture is concomitantly equal to the underlying trauma. No rib fracture, no trauma. But child ribs are still developing. They are not capable of doing the proper function of the ribs which adult does. So always remember, underlying contusions might be present despite the ribs being normal. Circulation, IV access is very much mandatory. We already saw that child's blood volume is only 80 ml per kg. A neonatal volume is only 80 ml per kg. So 4 kg neonate, only 400 ml of blood. So just imagine how much delicate the blood volume is here, and so you should take an early IV access for any type of trauma. And remember, only 20% of the loss, only 20%. In adults we talked about 15%, 15 to 30, 30 to 40, and more than 40. The adult deteriorates after 40% of the blood loss. In child, it is going to deteriorate just after 20% of the blood loss. And in case you are not able to place an IV cath, you are going to go for an intraosseous blood. So I never talked about intraosseous line in adults, but here you are going to do an intraosseous infusion in a child if IV cath is not easily secured. Disability, GCS. So modified GCS score is used here. We don't need to go into the details of the GCS, and check the blood glucose, because we talked about it in the child. Blood glucose are limited and child might die because of hypoxia and not brain injury. So always remember, when you are talking about disability, that is GCS, always check the blood glucose of the child, because the child's blood glucose might cause hypoxia and death of the child. And exposure, a child obviously needs to be exposed, but what is the difference? Always remember, head is total 20% of the body surface area and major evaporative loss. So child should be kept warm. Always the child should be kept warm. And I talked about coagulopathy when I was discussing in the chapter of trauma. So 1 degree of the temperature fall is equal to 10% coagulation factor loss. So 10% of the coagulation profile is going to be deranged if 1 degree temperature is going to be lost in a child. And always remember what is a concept called as a C aura. So you might have heard it in all your orthopedics chapters. What is that? A C aura is a spinal cord injury without associated radiological abnormality. So a spine might look absolutely normal like lungs, but there might be a spinal cord injury because the spine is more elastic than the cord. So actually the spine won't have any trauma, but the cord will have a trauma inside. So normal X-ray or CT does not exclude the spine injury. As in adults, what do we do? A spine trauma, we do a CT spine of the patient or X-rays of the patient to check for a spinal fracture. But here the spine is more flexible than spinal cord in the child. So always remember MRI is required if the neurological signs are present. So C aura. So what is that C aura? Spinal cord injury without radiological abnormality. So you should know that a basic approach to a pediatric child is going to be different for trauma than in adults, and what is the difference is very much important. So now coming to the pediatric hemorrhage and resuscitation. So blood volume, as I said, 80 ml per kg is in neonates. In child it is 60 to 70 ml per kg. Significant hemorrhage is always 20% volume. In adult it is almost 30 to 40%. Initial fluid is 10% warm, isotonic. We already talked about it. No hypotonic fluids in child because the child will develop brain edema as soon as you are going to give hypotonicity. And here also 10 ml per kg. So whatever child is going to come to you, blood volume, the resuscitation volume is 10 ml per kg. In adults, what we are going to do? We are going to give the Holiday-Segar formula. So we know that 100 ml per kg for first 10 kgs, 50 ml per kg for next 10 kgs, and 20 ml per kg thereafter. But here it is not like that. In child, 10 ml per kg warm crystallite to be given. O negative blood, if unstable child is there, you are going to transfuse O negative blood. Don't wait for cross matching. Just give the O negative blood to the child. The child is very much immune. The child can handle immune system very much well. So it is not like adults that he will develop reaction very soon. So if child is unstable, you suspect bleeding, straight away transfuse O negative blood. And coagulopathy risk is almost at 30 ml blood loss. And what happens is the fibrinogen, one important factor which I am going to talk to you is fibrinogen is in immature form till 12 months of age. So till 1 year the child is going to have immature fibrogen, and hence even a small risk of bleeding, and the child is going to start bleeding a lot. So small trauma and a lot of bleed you can suspect in a child. So tranexamic acid, again as I said, tranexamic acid we saw in our trauma chapter as well. So 15 mg per kg is given bolus. In adults we give 1 gram stat. Here no 1 gram stat, 50 mg per kg IV bolus when the child is going to present. Again it is to be given within 3 hours of injury. So tranexamic acid's role, we saw that crash 2 trial. What do we saw? Crash 2 trial. So crash 2 trial states that give it within 3 hours and if the patient is hemodynamically compromised. If the patient is hemodynamically stable, there is no role for giving any tranexamic acid. And thromboelastography, we already saw thromboelastography in trauma chapter. How do we check for coagulation parameters? How are we going to check for coagulation studies? We also saw the angle, the Tmax, the 30 minutes after the Tmax. We have seen everything in the trauma module. Go back and check the chapter for thromboelastography. So if you are giving to massive transfusions to the child, that is the time when you should take care of the coagulopathy, and there you are going to check for thromboelastography. Poor circulation. So because of the poor circulation in the child, there is more thrombomodulin. So what is different? Thrombomodulin is secreted and hence it activates protein C and protein S. Body feels that, oh, the blood vessels are not working fine. I should release something which is going to cause less coagulation so that the blood will come to me. So organs will release what is called as thrombomodulin, and that thrombomodulin is going to stimulate protein C and protein S. So whenever the thrombomodulin is going to stimulate protein C and protein S, we know that these are the anticoagulation factors. So whenever you are going to release them in the blood, naturally the blood flow is going to increase, and the child's body is thinking in that way that the blood is coming, not coming. So I'll dilute the blood so that blood comes to me. जैसे हम बात करते हैं कि बच्चों को क्या ही समझता है दुनियादारी के बारे में, इन द सिमिलर फैशन बच्चों को क्या ही समझता है फिजियोलॉजी के बारे में, इसलिए प्रोटीन सी प्रोटीन एस रिलीज कर रहे हैं बच्चे. सो ब्लीडिंग इज हैपनिंग एट वन प्लेस एंड दे आर सिक्रेटिंग प्रोटीन सी एंड प्रोटीन एस, हेंस इट इज गोइंग टू वर्सन कोएगुलोपैथी. एंड more than 30% blood loss, you are already in the trap. The child is almost having coagulopathy and fibrinolysis simultaneously, and 1% fall is 10% reduction in the clotting factors. So keep the child warm. So I hope it is clear to them. So what are the major injuries you are going to suspect? So chest trauma, it is because of blunt force. So flexible ribs, so lung contusion and pneumothorax without rib fractures, and there might be a possibility of missing out a hemothorax. So what you are going to do, mild pneumothorax, you gotta observe, don't put ICD immediately. Don't put ICD immediately. Here you can go for a clamshell thoracotomy. So what are the types of thoracotomy I will describe? So there is an one concept. So if this is the chest wall, the thoracotomy can be a median sternotomy. If you are going to approach the thorax anteriorly, it is called as an anterolateral thoracotomy. If you approach the thorax posteriorly, so this is called as a posterior thoracotomy. So posterior thorax, posterior thoracotomy, anterolateral thoracotomy, median sternotomy. And if you are going to open the thorax bilaterally like this, it is called as a clamshell thoracotomy. So you open the thorax like a book, so one goes down, one part comes down and another part is going to come up, so it is called as a clamshell thoracotomy. So in child you can go for a clamshell thoracotomy in fifth intercostal space for emergency access. It is going to allow the lung decompression and supradiaphragmatic aortic control. So we already saw in emergency room thoracotomy, you do a thoracotomy and you are going to cross clamp the aorta so that the blood supply to the head is going to remain patent. So it is called as a clamshell thoracotomy. Handlebar injury. So in adults also we said that if the most of the times the child starts playing and the handlebar is going to strike the abdomen, it might lead to a duodenal hematoma and bilious vomiting. So there might be a pancreatic injury present. So we already have seen this in the chapter of adult trauma as well. So in duodenal hematoma, you can conserve using a nasogastric tube. You don't need to operate because the healing tendency is faster. The small perforations might heal off. But if at all it is required, you can go for, if the pancreatic pseudocyst is formed in the child because of trauma, then that traumatic pseudocyst can be drained into the stomach later on. We'll see how the pseudocyst develops in the chapter of pancreas. Seat belt. So we know that there are some things which is called as a lap seat in the car. So whenever a small child is made to sit in the car, it is called as a lap seat. So that seat belt also can cause injury, and it can lead to a delayed injury up to 72 hours. So in adult, the seat belt injuries will call mesenteric tear. In child, they can cause what is called as a chance fracture. So lumbar spine fracture. Always remember, in any adults or in any infants, where is the most common site of fracture? Wherever one part of the vertebra ends and other starts. So what do you mean? When the cervical vertebra is going to end and thoracic is going to start, that C7T1 junction is most vulnerable. Why? Because cervical spine is mobile, thorax spine is not mobile. Same happens with the thoracolumbar region. So thorax T12 and L1, both the spines. The L1 lumbar is mobile because it is going to go for flexion, extension, lateral rotation. But thorax spine is not that much mobile. So most common site of injury for any spine is going to be the junction between the two regions. So cervicothoracic region or the thoracoabdominal region. So thoracoabdominal region fracture is nothing but a chance fracture where there is going to be a fracture of lumbar spine and there might be some small bowel injury as well. So you should have high index of suspicion. So whenever the baby is going to come to you from with the mother, we had an accident, this is the lap seat, मुझे थोड़ा लग गया है, मुझे छोड़ो, ये बेबी को देखो. नहीं, कुछ नहीं, आपको नहीं हुआ, उसको क्या ही होगा, वो तो लैप सीट में बैठा था मस्त आराम से. No, 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 no. You have to suspect injury, do a CT scan. You might find something. Solid organ injury. As I told you, in adults, the blunt trauma most commonly damages the spleen. Here it is going to be liver. So any solid organ injury, what I am trying to tell you, because the child is very much vulnerable, it cannot have bed rest like human beings. हम ह्यूमंस को बोल सकते हैं घर जाके 2 हफ्ते काम करो, वैसे भी हम काम चोर रहते हैं, हमें काम नहीं करना होता है, घर जाके मैं 2 के 4 हफ्ते भी सोने को तैयार हूं, डॉक्टर ऑन पेपर लिख के दो. So they are going to ask you for 4 weeks of holidays unnecessarily, but it is not in the case of child. So whenever a child has a solid organ injury, a grade 1 and grade 2 can have strict bed rest for only 2 days. And if the trauma is going to be grade 3 or grade 4, minimum 48 hours of strict bed rest is required. In case required, you can intubate the child and you can give sedation to the child because strict bed rest is required. If not, then it is going to cause a lot of problems. And always remember, no sports for next 6 weeks. So this typical thing your mother is going to ask you, that क्या करूं मैं इसका, ये खेलने जाता है, सुनता नहीं. So 6 weeks no play. And usually again, as in adults, no operative management preferred in a hemodynamically stable child. So all solid organ injuries are preserved in adults and in child unless they are going hemodynamically unstable. Simple logic, वैसे ही पता होना चाहिए. Renal trauma, again remember, in cases of renal trauma, the child might develop scarring later on. So one important point which is not there in adults but it is there in child, that any type of renal trauma, there might be massive bleeding because kidneys are not well developed. So that is the reason when there might be the renal scarring, and that scarring might lead to a CKD later on in the child. So you should always do a DMSA scan. So there are 2 scans in nuclear imaging which tell the renal function. One is the DTPA scan, another is a DMSA scan. So DTPA will tell about the GFR, the functioning of the kidneys, and DMSA will tell about the scarring. So S is present, so S for scarring. So to check for the scarring, you can do a DMSA scan in the child so that you can assess the post-trauma renal function. And DMSA is done at 3 months, and nephrology follow-up is required. You might need to do a serial serum creat levels later on, so it is very much important. One thing always suspect in a child of trauma is non-accidental injuries. So you are a medical officer, you are a resident, and you suspect that the child has trauma. The parents might tell you that the child fell down from the bed, the child was in the car, the child actually dashed somewhere. No, always suspect something which is called as a non-accidental injury. So there might be some non-accidental injury where there are bruises on the cheeks or on the genital, and rarely these are the accidental sites. So there might be less of the trauma to the cheek. Many times the parents might have what is called as, that they might beat up the child in lower socioeconomic class. It is very much common, so always keep this in mind. And bruises are of different ages, so you have to just take proper history, and the history might be inconsistent with the injury pattern, and they might present delayed. So you might find one contusion healing there, fresh contusion on the cheek. So you should know that. The child parents might not know that, but you should be knowing that. So stage bruises can also occur in leukemia. So what is the differential diagnosis? So because of the leukemia, there might be blood clotting into the skin. So you might feel that the parents have beaten him up. So always investigate the child. So always investigate the child. Non-accidental injuries can either be a battered baby syndrome, somewhere the child has been bit by the parents, or there might be something which is like a leukemia or bleeding disorders which might have caused multiple contusions. What happens is, मदर के हाथ से गलती से बच्चा छूट जाता है, तो उसको लगता है अरे मेरे वजह से उसको ब्रूज आया. इट इज नॉट बिकॉज ऑफ हर फॉल्ट, इट माइट बी बिकॉज ऑफ सम ब्लीडिंग डायस्टेसिस और ल्यूकेमिया. सो फर्स्ट you are going to check that if the baby is not having any something like that. So it is very much important. And as I said, damage control, same. We talked about two things in surgery. In trauma we talked about DCS and ETC. What is DCS and ETC? DCS is damage control resuscitation and ETC is early total care. So if the patient is vitally stable and the patient requires a definitive management, you can go for what is called as a early total care. But when the patient is unstable, you are going to go for what is called as a damage control resuscitation or damage control surgery. So in damage control surgery, the first we know that the lethal triad of trauma, it is nothing but hypothermia, acidosis and coagulopathy, and they are going as a vicious cycle. So one thing sets in, other is going to be disturbed, other disturbs, the third is disturbed, the third will disturb the first one. So it is a vicious cycle. So first break the vicious cycle. So first you are going to control the bleeding and contamination, then you are going to do ICU resuscitation and then definitive surgery. It is the same which goes on with the adults. So here we have ended the chapter of your pediatric trauma. Tomorrow we will start with the pediatric urology, and then we will start with what is called as head, neck and neurosurgery. So I hope things are clear to you. If you have any doubts, you can post to me on WhatsApp or Instagram, or you can post them in the chat section as well. I'll be more than happy to come up with your doubts and discuss them up. So I hope it is clear. A small chapter of pediatric urology, a 10-minute session tomorrow, and then we'll going to proceed to what is called as the neurosurgery module, head and neck. So in very nice chapters, salivary glands, head neck region, anatomy of the neck, then different lymph nodes, oral malignancies, neurosurgeries. So it is going to be a whole lot of new things. So we'll start it off tomorrow itself. So tomorrow is an Independence Day, so I'll tell about the lecture if it is going to be there, because I think I also need to be some independent tomorrow. So I'll tell about it tomorrow by the evening time, but let's see if we can do it tomorrow so that on Sunday we all can have a break. So thanks for attending the lecture. Hope you have enjoyed it. If you have any doubts, I'll be more than happy to help. So till then, take care, bye bye and good night.